Good afternoon, one and all. A very warm welcome to each one of you. Friends, I'm so happy to be back with all of you. And today is Ashtami, the day 8th of Navratri, where we are celebrating, the good over evil. We pray to Ma Durga that all the evil gets over and win. So today we are going to continue in our daily lives also. We are going to fight over something which most of the women struggle with during their adolescence and during their reproductive years. We're all together here to fight and win over the PCOS. So we will be a Vijeta and win over the evil that is PCOS. Friends, good afternoon, everybody. My name is Ruby Sound, and I represent the PCOS Society. I'm the co-chair of Special Interest Group on Public Awareness. I am the committee member of the society, and I'm also leading this program called Vijeta, which we are presenting today. Many of you who have been attending this program over the last few weeks, let me just quickly tell you that we continue with the series. And today we are in the episode where we are going to talk a little more on ovulation induction and continue from where we stopped in the last week. Friends, for those who have not been a part of our series, let me tell you that Vijeta is a program. It's an educational initiative by the PCOS Society of India, where we are talking about the PCOS in 3 or 4 seasons, and every season has multiple episodes. This is season 1, and we have already done 3 to 4 episodes on different aspects, right from the diagnosis to the lifestyle management and continuing with the medical management of PCOS. And we were very lucky that the last episode was, the lecture was given by Dr. Duru Shah, madam, who is the founder president and who has conceived this program. Ma'am, last time spoke about ovulation induction. Okay, so for those who don't know, we are trying to help people, women especially, who are having PCOS and a difficulty in conceiving. And among the medical management, ovulation induction can either be done with oral medication or with injectables. So today we are going to continue and we are going to talk about ovulation induction with the help of injectables or injectable hormones. Okay. We are also going to cover a little more beyond that. Ma'am will elaborate and tell you a little more about what is IUI, how it is done, and what are the advantages and disadvantages of the same. Not only that, ma'am is also going to extend her talk to laparoscopic ovarian drilling and a little bit about bariatric surgery. So there's a lot to learn in today's episode. We are going to have another session which is going to come hereafter. We will cover all the treatment modalities in the today's and the next session. So I request all of you to stay hooked on to today's session. But before we go ahead, let us quickly do a small quiz. And I just love doing that because it just tells me how much do you currently know and how much will you learn after the session. So we're going to run a quick poll. Now, this poll is actually a set of 8 questions. Okay. Each question will be displayed on your screen. You need to answer in a given stipulated time of about 30 seconds. Okay. Each one of you will get only one opportunity to answer either as true or false. So I request the question 1 to be displayed on the screen and request all the participants to kindly participate and answer the first question. The first question says, many women with PCOS and irregular periods do not conceive spontaneously. The question is, many women with PCOS and irregular periods do not conceive spontaneously. Is it true or is it false? So the question is asking, do they need any treatment or do they conceive spontaneously? So there is a mixed review coming in. There are only 5 seconds remaining, and half of you have said yes, or rather more than half. Now, at the time end, 60% of you have told that they do not conceive spontaneously, and 40% say that they may conceive. Let's get the answer from Dr. Durusha madam during her presentation. We have the second question now on the screen. The second question is, injectable hormones for ovulation induction are used for all PCOS women having difficulty to get pregnant. The question is, injectable hormones for ovulation induction are used for all women having difficulty getting pregnant. Please answer either as true or as yes. We have 10 more seconds for those of you who have not answered so far. Majority of you are saying that it is false, and only 20% of you are saying that injectable hormones are used for all PCOS women. That's a very interesting question. We go to the next question. I will give you all the answers, right or wrong, at the end of the session. Question number 3. We can safely use hormone injections for fertility without any medical assistance. Now, the question is, can we use these hormonal injections for fertility without any medical assistance? Can they be self-administered? Is what the question is. Please answer either as true or as false. So, majority of you have been answering as false so far, last few seconds, and 100%. This means all of you are saying that you can't be taking this injection without any medical assistance. Oh, but last, there's some change. 17% just said that, okay, they may be taken. Okay, next question. Over to question number 4, please. Question number 4 is, the risks of injectable hormone treatment are OHSS, which is ovarian hyperstimulation syndrome, and multiple pregnancies. So the risk of injectable hormone treatment are ovarian hyperstimulation syndrome and multiple pregnancies. Are these the risks? So please answer as true or as false. So majority of you, in fact, all 100% of people, everyone has answered that yes, the risk is OHS and multiple pregnancies. Okay, let's see at the end of the session. Question number 5 on the screen is, laparoscopic drilling is offered to women who do not respond to medical ovulation induction. Is it true or is it false? Laparoscopic drilling is offered to women who do not respond to medical ovulation induction. Of course, it may vary from person to person, but there are standard guidelines which will tell you that is laparoscopic drilling offered to women who do not respond to medical ovulation induction. So we have a mixed review here. We have 60% of people saying true and 40% saying false. So we will get to know the answer during the later part of the session. Question number 6 is, laparoscopic drilling is the first line for ovulation induction. Is the first line of ovulation induction laparoscopic drilling? This is the question. So please answer as true, false. If you think that yes, laparoscopic drilling is the first line, please answer true. And if you think no, it is not the first line of treatment, please answer as false. We have difference of opinion here once again. About 83% of people saying false and 17% agree that this is a first line of treatment. We have last 2 questions coming up on the screen. Question number 7 is, bariatric surgery should be offered to all obese women desiring fertility. So the question is, bariatric surgery should be offered to all obese women desiring fertility. Is it true or is it false? Of course, we will be discussing that which women will be suggested bariatric surgery. But what is your opinion on this? 33% so far saying that should be offered to all women, and 67% are saying it is false. Okay, we have the last question coming up on the screen for everyone. Okay, PCOS women who over-respond to injectable hormones should be recommended IVF. Is it true or false? PCOS women who over-respond, okay, to injectable hormones should be recommended IVF. Is there a criteria for IVF for PCOS women? Please answer as true or false. Okay, we have a very clear-cut opinion. No, we still have some people with a different opinion coming up. Rajali, last 3 seconds on the screen for those who have not answered. So there are about 25% of people who are saying true, and about 75 or 1/4 of people agree, and 3/4 don't agree. We come to an end of this 3 poll questions, which are very interesting. We will get all the answers by Dr. Duru ma'am. So without wasting any further time, I will take the session forward and give you a quick introduction about Dr. Duru madam. We all know ma'am, and she doesn't require any introduction. But let me tell you that she is the founder president of the PCOS Society of India. She is the director of Gynac Wall, which is a center for women's health and fertility. She is a panelist. She has received several awards over the years, and her dedication and love for public outreach programs is why we are all here together. So I request ma'am to kindly give the presentation to the audience and answer all the questions which I asked. Over to you, ma'am. Ma'am, I request you to unmute yourself as well as you
Yes,
put your slides on the
I'm trying
screen.
to do that. I'm trying to unmute myself. Thank you so much. I hope you can see my screen.
Yes, ma'am.
Can you see my screen, Ruby?
Yes, ma'am, it is visible.
Good, good. Thank you so much. Thank you very much, ladies and gentlemen. If there are any gentlemen in the audience, I'll be very delighted because I think PCOS affects every person's either daughter, wife, sister, mother, whoever. So even the men in the audience, if they are there, it should really help you to understand what your female partner or female family member is going through. So, coming back to our talk on PCOS and fertility, the last episode we talked about ovulation induction, wherein we talked about oral, medications which you can give to induce ovulation, and we talked about ovulation, which means women who have irregular periods, they produce maybe one egg every 2-3 months whenever they are ovulating, whenever they are menstruating. In that, if they've got a cycle of 3 months, every 3 months getting a period, then they have only one egg which they produce, so it reduces their chances of conception. And therefore the management part depends on bringing about ovulation. And we discussed on what exactly is normal ovulation. So I'm just revising this for you because it's a little difficult for a lay person to understand. But I'm going to re-explain this menstrual cycle to you. So what really happens is within the ovary, there are plenty of eggs lying inside the ovary, depending on the age of the patient. If a woman is young, she has many eggs inside her ovary, whilst as she grows older, she keeps releasing, almost 20 to 25 eggs every month. So in short, she's losing about 20 to 25 eggs every month. And what really happens is that this is the early part of the menstrual cycle. Till the third day of the period, all these eggs are hanging around in the ovary. Then around the fourth or fifth day of the period, the hormone from the pituitary gland, from the brain, this hormone is called FSH. It starts rising in the blood, and as it rises in the blood, one of these eggs starts responding. So it is the selection of the most dominant follicle. It's the selection of the best egg which gets done by the FSH. And it allows that one egg to grow from a small egg to a large egg, which is about 18 millimeters in size, or 18 to 20. So that is considered as a mature egg, which is capable of being fertilized by the sperm which enters the human body. Whilst all the other eggs, they undergo atresia, means they just die a natural death. And it is only this one egg which grows further, and then it gets ovulated, it gets released from the ovary, meets the sperm in the fallopian tube, makes an embryo, and then implants in the uterus. So this is the normal physiology, and therefore women who are getting a period every 2 to 3 months, they are producing only one such egg every 3 months, and therefore their capacity to get pregnant is only once every 3 months. Whilst a woman who's getting a period every month, she's having an opportunity to produce a baby every month whenever she ovulates. Now, this is a sort of a very short explanation of what we discussed in detail the last time. And I'm just refreshing your mind on what is normal ovulation. Now, coming to ovulation induction. Why do we do ovulation induction? Means we are giving something to the patient. We are giving her a medication by which instead of her releasing an egg every 3 months or 2 months or 1.5 months, depending on her period, she is helped to release an egg, sort of every month. That is called ovulation induction, where one single egg is released in a woman who's got very delayed periods. Secondly, it is used in women who do not ovulate at all. So there are women who don't get their periods for 6 months. So in those women also, you can use the drug to bring on an ovulation, which is bringing out one egg, which we do usually with oral medication, but occasionally, even with the oral medication, instead of one egg coming out, you may have two eggs coming out or three eggs coming out. But that's what usually happens. Whilst on the other hand, we have a situation called controlled ovarian stimulation. Means we are actually stimulating the ovary in a very controlled way to make sure that the woman doesn't produce too many eggs. Because multiple eggs start developing. Now, from where do these eggs come? Now, if you look at it naturally, when you go back to the cycle, these are those eggs which were growing over here. But they were not having the stimulation from this FSH. So what we do is when we give medication, we are just trying to save these eggs from undergoing a natural death. We allow them also to grow with the help of the medication we are giving to the lady. And that is why instead of one egg, she produces many more eggs, which she needs when she's trying to get pregnant, because out of every 3 eggs, it is only 1 egg which is really normal and is capable of getting fertilized. That's a normal process. So when you do controlled ovarian stimulation, you're producing multiple eggs who are actually, they may be already ovulating. But why we want to increase the number of eggs is because we want her to have an increased chance of conception. Because if she releases 1 egg, and if that 1 egg is not normal, her chance of conception or conceiving are much lower than when she produces 2 to 3 eggs. But on the other hand, the disadvantage is that if she produces 2 or 3 eggs, and if all 3 are normal, then she'll end up with triplets. So the question is, what do we do? And therefore, we are controlling this ovulation. We are making sure that she doesn't produce more than 3 eggs at any cost. So the amount of medication we give depends on this particular principle. So in short, when we give oral medication, which we discussed the last time, sometimes those medications do not help us. It does not help us because of various reasons in a PCOS woman. But if we find that those oral medications are not helping us by bringing on ovulation induction, then we will start using hormone injections, which we are going to discuss today. And why do we use those injections and how do we use them? So these hormonal injections is a second-line treatment option in women. The first-line treatment, as we had mentioned earlier, it was basically lifestyle changes. That is the first thing you have to start with. After you've brought in the lifestyle changes in terms of a healthy diet, good nutrition, bringing on the ideal weight, either weight gain or weight loss, usually weight loss. In 20% women, it may be weight development. But at the same time, that's the first line. Following which we do ovulation induction with oral medication. We try for 2 to 3 months, and then if the patient doesn't respond, then we go to the second line option of using injectables. Now, the intent is to produce not more than 3 eggs. But in an IVF cycle, when we are doing IVF, which we'll discuss in the next episode, we are trying to produce many more eggs because we want to get those eggs out, fertilize them. We see the eggs under the microscope. We make sure whether they are getting fertilized or not. We make sure whether the eggs look good or not, which we are not able to detect when we do it only under ultrasound control. But the ultrasound helps us in monitoring to make sure whether the eggs are too many in number, because if we are going to do a cycle without IVF, we cannot afford to have more than 2 to 3 eggs growing. So therefore, the dose of these injections is highly controlled to avoid excessive eggs to mature. And because too many eggs being released can cause increased amount of complications. So let's see what kind of complications they will cause. So how do we monitor? We monitor with ultrasound, wherein we call the patient every 2 to 3 days to see how the egg is growing. If the egg is growing normally the way it should, and it's going at a good pace, then we continue the same dose of injections. But if we find that the egg is not growing too well after 3 to 4 days of daily injections, then we'll have to increase the dose very, very gradually by just maybe half an ampule, because they're very strong injections. We also do their hormone levels in the blood, which helps us to assess whether the egg is really producing a lot of estrogen, because the more estrogen it produces, higher is the risk of problems with medication. And hence, All patients who are using these injections need to be monitored by a physician through hormone levels or through ultrasound, so that you make sure you're not creating complications for the patient. Rather than helping her, we don't want to harass her. So that is why we monitor. So the kind of injections we use are different types. Now, if you go into the history of how all this developed, now we know that we need to use FSH, which comes from the brain of a woman. But in those days, many years ago, when the research was on, they used to extract this FSH from the urine of menopausal women. If you know that when a woman reaches menopause, there are no eggs left in the ovaries, and the signal goes to the brain that there's nothing growing here, and the pituitary gland, which is in the brain, goes on secreting more and more of FSH so that they can help to make the eggs grow. But unfortunately, there are no eggs, so those eggs don't grow. But in a woman who's got enough eggs, the eggs will grow. If she's got too many eggs will grow. And therefore, we need to keep a control over the amount of eggs which are coming out. So it's a very nice history to go back into, that when they were doing this research, they found that menopausal women, that is the ones who have stopped menstruating, have got a lot of FSH in their urine. So there used to be the people who are doing the research used to go with buckets to everybody's home, all the menopausal women's home, and collect the urine which has been collected over 24 hours in each home. And those women, obviously, probably they were getting compensated for collecting their urine in a bucket. And that buckets used to go to the lab and FSH used to be extracted. Then came the era of human menopausal gonadotrophins that was made from the urine of menopausal women. So HMG stands for human menopausal gonadotrophins. And urinary FSH is where, you see, HMG consists of two hormones, FSH and LH, whilst urinary FSH contains only FSH. It's sort of separated out from the product. And then the last one which came was the recombinant hormone, which is manufactured in the laboratory synthetically. It's not an actual hormone which has come from the brain of the pituitary gland, or it's not come from the urine of the menopausal women. But it has been manufactured in the laboratory, and it is a very powerful product. And this can be self-administered. It's administered as an injection in the fat of your body, just like how you use insulin. Similarly, it is self-injected by the patient through a pen. You have a pen, you adjust the dose, and you inject. So it's very simple, not painful, but it has to be also monitored. Basically, all these products need to be monitored and make sure that it's not causing problems. Now, why did these different preparations come up? Actually, the first one which I'm talking about is not really urinary FSH. It is more about pituitary. It was removed from the pituitary gland from the brain when there were autopsies in the postmortems were being done for any person who was no more. The pituitary gland was removed from the brain, and from that the FSH was extracted. Then they came down to human menopausal gonadotrophin, which came from the urine of menopausal women. And the third thing is with the recombinant or the self-injectable injections. The advantage of those are that they do not contain any human product. See, the concerns have been that when you're giving a human product to somebody, are you going to cause any kind of allergic reaction? Are you going to transmit any infection? But all data shows that there's no infection being transmitted, and therefore it's not necessary to use only the recombinant ones. All are equally effective, and there's been no difference found in the live birth rate, in the pregnancy rate, in the multiple pregnancy rate, or the miscarriage rate with any of the injections which you use. Recombinant FSH is the most expensive. Patient uses it herself, whilst the injections which are given from here are given by of course, this product is no longer in use, but this product can be given by the physician or the nurse to the patient, and this is something which gives equally good results. So how do we use the gonadotrophins? We start with a dose which may be high dose first, starting with say 4 injections together, all given together for 4 to 5 days. Then the patient comes in for her ultrasound scan. You see how many eggs are growing, and you also do the hormone levels of estrogen. You continue with the injection, or you may reduce the dose. If you find too many eggs are growing, then you reduce the dose and you reduce the number of eggs which are growing. And you go on like this every few days and go on reducing the dose till you find that what number of eggs you're looking at are growing and the others are not growing. And you keep monitoring them with ultrasound, where you see the eggs, and you keep monitoring them with the blood level of E2 to understand whether the egg has become mature or not. When the eggs are ready, then you give the trigger, as we call it, which we discussed the last time. When you give the trigger, after 36 hours, the eggs come out of these follicles and are available to the sperm in the fallopian tube to get fertilized. Now, coming to why do we want to monitor? As I told you, we need to monitor these cycles. The reason is because if the ovaries get excessively stimulated, they get too much of hormone growing within them, too much of estrogen getting secreted, it can give rise to ovarian hyperstimulation syndrome. I'll talk to you about what it is. And the second thing is gives a higher chance of getting multiple pregnancy, because if there are many more eggs. Now, if you end up with having 3 babies together inside your uterus, it becomes a complication. So therefore, in those cases, if we feel that too many eggs have grown, which we cannot control, then we cancel the cycle, which we can cancel even in the previous part. Like say, if I see here too many eggs growing, I can cancel the cycle here and tell the patient, no, if you go ahead, you'll get too many eggs. This dose is not right for you. I need to step down on your dose. Or if you find that there are only 2 or 3 eggs growing, then you continue with the same dose, or you may lower your dose. So that adjustment of dose tends to happen. There are some centers who start with a smaller dose and build it up to a higher dose if needed. There are some centers who work this way. So each one has their own way of functioning, and that is how we would work. In patients who have got PCOS, means they've got too many eggs in their ovaries, we always start with a very small dose first. Give it for a few days, see the response, and if we find it's not sufficient, then we will increase the dose. That is how we work to make it safe for the patient. Now, what happens over here is that if we see too many eggs developing, we may either cancel the cycle, tell the patient it's not safe to go ahead, stop it, because these injections are expensive. We don't want to keep wasting her money by going on giving the injections and telling her last minute that you got too many eggs growing. Or we tell her that we need to convert this to IVF, because when we do IVF, we are extracting those eggs from inside her body. We bring the eggs out. We don't let those eggs get released in the abdomen. So the reason is that if those eggs are released in the abdomen, the complications are much higher. Whilst if you pull the eggs out and you sort of freeze them, don't try to get her pregnant in that cycle. Just get the eggs out, make the embryos and freeze them and cancel that cycle. Don't waste the eggs. And then you go into the next cycle and then put the eggs into the next cycle when she doesn't have too many eggs growing in her uterus, in her ovaries. So this is how we decide what to do with the cycle. But in short, what you have to remember, that if we use injections, we have to monitor, number one. We have to make sure that we don't produce more than 3 eggs at a time. Or if we see that there are more eggs growing, we try talking to the patient, counseling her, and then making her and us both make a joint decision whether we want to go ahead with the cycle or we want to cancel the cycle. If we go ahead with the cycle, we retrieve the eggs out of the ovaries. We don't let them rupture inside, because if they ovulate inside, she's got a higher risk of developing multiple babies. And in the past, having these multiple babies was considered as a great feat. It's a great accomplishment. As a matter of fact, people used to display it in newspapers right in the beginning when fertility care started, where if you have 3 babies in a row and 4 babies in a row, it was on headlines of news. But today we consider it as a complication, and therefore, we prevent such a situation happening. So what happens with ovarian hyperstimulation syndrome? What happens is the ovaries get very large and they have lot of eggs growing here. Lot of eggs. Now, normally when we are giving a small dose of gonadotrophins, we don't expect this to happen. But when you're doing the first cycle, you never know with a PCOS woman. They behave a little, not that the women are behaving erratic, the ovaries are behaving erratically. They are oversensitive to the hormones we use. Sometimes they will not respond with a small dose. And as soon as you increase the dose, the ovaries will blow up. So especially in the first cycle, becomes almost like a cycle where we are not sure what to expect, and therefore we go slow so that we can prevent this problem. So here on ultrasound they call it kissing of the ovaries. So here is one ovary and the other ovary is here. So they are both like almost stuck to each other, like kissing each other, but it's not really supposed to be like that. So the patient gets very uncomfortable. She's got a lot of bloating, she's got nausea, she's got vomiting, she's got fluid collected in the abdomen, and the amount of urine she passes out is low. So once we know that this situation is happening, we start correcting the problem, and it can be easily treated, not that it cannot be treated when it's treated in good time. The only thing is we prevent a pregnancy in that cycle, because if she gets pregnant, then the problem gets worse. So we cancel the cycle, or we convert it into IVF where we get the eggs out, but don't let her get pregnant. And then we can give medication and we can bring it all under control. Now, what is the success and risk in women with PCOS who are under the age of 38? Why am I saying under age of 38? Because as the age increases, the chances of these number of eggs in the ovaries goes on reducing. So your chances of having all these problems, etc., will be much less if you try to get pregnant after the age of 38 if you're a PCOS woman. But you must remember that there's a, all women are born, as I've talked the last time, with a fixed number of eggs within their ovaries. Even if they have got a lot of eggs as PCOS women, but that age factor comes in the way and causes problems even for women with PCOS. Even though they may have a lot of eggs, but because of the aging process, the chances of conception become lower. Now, if you compare the oral medication, where we talked last time about clomiphene and we talked about letrozole, if we are giving these oral medications and not doing an IUI, the chances of pregnancy per cycle of treatment is only about 4 to 6%. When we add IUI or intrauterine insemination to it, the chances double to 10 to 12% per cycle. When we do gonadotrophins with IUI, the chances increase to 20 to 26% per cycle. Now, the reason for this is not because of the 3 eggs that you're producing, but it is also because of when we use these oral drugs, sometimes it affects the lining of the uterus and does not allow it to grow well. The lining of the uterus remains thin and does not allow a pregnancy to occur. So even though ovulation may occur, but pregnancy may not occur as much. But when we use the injections, that thinning of the endometrium usually goes away, and you get a good endometrium for the embryos to implant. And then when you add an IUI to it, your chances go up to almost 20 to 26% per cycle. But if you count over a period of 3 months, the patient is taking the same treatment for 3 months, one in a row. And if you count it as a cumulative pregnancy rate over 3 cycles, this 4 to 6% becomes 10% or 10 to 12%. This becomes 15 to 20% with IUI. And with gonadotrophin and IUI, it goes to almost 36%. So at the end of 3 months of treatment with gonadotrophin injections and IUI, almost 1/3 of the patients, or 35% of the patients, become pregnant without doing any IVF. Now, this is for women who have got tubes are open, there's no other medical disorder within them, they are otherwise all okay, but they are PCOS, their hormones have been corrected, then the chances of pregnancy become pretty high, and you can save yourself a lot of cost of not doing IVF unless it is absolutely necessary. So this IUI procedure is IUI, as I talked about, intrauterine insemination. I'm revising this for people who were not there the last time. It involves collecting the husband's sperm cleaning up the semen sample, taking off all the seminal plasma, means this plasma contains some products which make the uterus contract. So if you put the semen in straight into the uterus, it will cause severe cramps in the uterus. Or if that semen has even a little infection, it can cause a lot of infection inside. In the natural process, when a woman has intercourse, the semen gets cleaned at the level of the cervix. So in short, when the semen is deposited in the vagina over here, this cervix, this is the part where they get cleaned up naturally. Only the good sperms are allowed to go up. But when we are doing an IUI, we pass a catheter inside here and we put the semen sample here. If we don't wash the sample, we are pushing in a lot of this plasma and other products and infection inside, which can cause trouble to her. So we ask the husband to collect the sample in a container. We clean it, we wash it, which takes about 40 to 45 minutes procedure. And then that sample, which is a very, very small sample, is put inside with a very fine catheter into the uterus. You don't require any anesthesia for it. It's a very simple process. And it is put inside when the woman is ovulating, when she releases her egg. You don't do it every day. You only do it when you release an egg, and that is seen on the ultrasound. It's very useful in patients who have got unexplained for infertility, where we are not finding any reason that she's infertile. Her tubes are open, her ovaries are, she's ovulating, the lining is growing well, the sperms are good, but we find no reason why she's not conceiving. So it helps in those patients. Or it really helps in patients where the husband has a problem in his sperm. If the sperms are not very motile or not very agile to reach the egg, because they have to travel this distance all the way from here, going up to here, which takes them, about almost some time, maybe more than an hour or two. And therefore, we want sperms which are motile and will reach the egg, which is waiting here in the fallopian tube for the sperm to arrive. So in short, if the sperms are not very good in motility, then in those patients, putting in the washed sperm inside the uterus right here, reduces the distance the sperm has to travel. The sperm is injected here, and then the sperm has to travel only this much distance, which helps the woman to get pregnant faster. The success rate for natural conception, as we said, is 5% per cycle, but with the IUI, it can go up to 15 to 20%, depending on the number of eggs which have been released. Now, suppose there's one egg, the chance of IUI, and this, as I mentioned to you earlier, would be about, say, 12% to 15%. But if you have 2 eggs or 3 eggs, then the chances increase a little bit more. So in short, it depends on what the woman's age is, because if her age is 38, 39, chances of conception are low. But if she's younger, she's 28, 29, then her chances are higher. We do not know what the cause. It depends on the cause of the infertility. If she's got endometriosis, then IUI really doesn't help really much. We may try, but IVF gives us the best results. It also depends on what medicines we are using, whether we are using oral tablets or we are using the injections. As I showed you in the earlier slide, it's the injections which give us a better pregnancy rate. And lastly is the sperm count of the male partner. Now, if patients do not ovulate with the injections also, and you're stuck and you don't know how to make that woman ovulate, because quite a few of these PCOS women have large ovaries, and they are very smooth surfaced, like almost like they are called like pigeon eggs they look. And that is what was the first description given to ovaries of PCOS women 300 years ago, where they were doing such postmortems on women who had a lot of hair growing on their face, not conceiving. And when they could have a chance to do a biopsy of those ovaries, they looked at the ovaries. In those days, they didn't have a laparoscope. So either they opened the abdomen and looked at it and took a biopsy, looked at the ovaries. They described them as pigeon eggs. So I don't know how many of you have seen pigeon eggs, but polycystic ovaries have been described to pigeon eggs. And therefore, in these cases, what we do, since this ovary is producing a lot of male hormone, which comes from the surface of the ovary, through the laparoscope, we put in sort of a point wherein we make about 4 to 5 holes in these ovaries. They are not going very deep inside, just about 4 millimeter deep. And it's a pointed instrument with heat. We make that those little holes in the ovaries, and that is called laparoscopic ovarian drilling. And therefore, we use heat energy for this, and we destroy some of the tissue of this ovary, which is actually producing the male hormone. And once you bring that male hormone down, the chances of ovulation are better. This study, which has been done in February 2020, they looked at 38 research studies which have been done where they compared the oral drugs with the laparoscopic ovarian drilling. Even oral drugs and injections together, they compared with laparoscopic ovarian drilling. And what did they see? What are the things they compared? They looked at the oral tablets along with metformin, which we discussed the last time, letrozole without the metformin, gonadotropin injections by themselves, and tamoxifen, which is another oral drug. And they compared them all with this laparoscopic ovarian drilling. And what they found is that the live birth following the medical ovulation induction, means using metformin, using letrozole, using these oral medications or even injections, they found that the live birth rate came to about 42%. Why they say live birth? Because there are many patients who get pregnant, but then some percentage end up with abortions or miscarriages. Then the live birth rate following laparoscopic ovarian drilling was anywhere between 28% to 40%, which is equally good as this. The only difference being this you will do every month. You will give medication and monitor, whilst this you do only once, and the effect will last for about 1.5 to 2 years. Very good for patients with certain parameters by which the doctor decides, which patient is the right patient to do it for. But it also has advantages and disadvantages, wherein when you do the drilling, it reduces the multiple pregnancy rate. It is effective for almost 1 to 2 years. The patient doesn't have to keep going back to the clinic for a lot of monitoring or a lot of injections. And of course, excessive stimulation is avoided because of the injections. But there is a surgical risk involved because it's a surgical procedure. Sometimes there are some adhesions which develop. Adhesions means one organ gets stuck to another organ through very flimsy sort of curtain-like adhesions, but which can lead to further infertility because it affects the tubal function. Then sometimes when you have made these holes in the ovaries, they continue to bleed. And then because they are bleeding, we have to control that bleeding. So we apply more heat. The more heat you apply, you're injuring the surrounding tissues, means you're damaging the surrounding tissues. And the eggs which are in those surrounding tissues in the ovary are also getting destroyed. So there could be decrease in the number of eggs remaining in the ovaries and possible risk of premature menopause later in life. So in short, each procedure has its own complications and side effects. And of course, it's the doctor who's treating you who is the best judge of what is good for you and what is not good for you. Of course, we always discuss the pros and cons with the patients, bring them into a joint discussion, and then make a decision. Now, coming to bariatric surgery, which is a surgery which you do when the BMI of the patient is more than 35. So if she's very obese and she's got a lot of complications like diabetes, high cholesterol, hypertension, means high blood pressure, she's not able to lose weight, she's just not moving. In those cases, these surgeries of the stomach have been created. One is the restrictive type, where they reduce the size of the stomach, and the other is the malabsorptive, wherein they don't allow the nutrition to get absorbed. So there are various procedures like gastric banding, bypass, balloon, sleeve gastrectomy, and it depends on each physician or surgeon who does this surgery, who will decide what is good for you. And this is a weight loss said that after 2 years, a weight loss is almost 50%. But the benefits and risks are both there. It corrects ovulation, it helps the egg to come out, it reduces the male hormone, it improves the sexual function. But the patient who's undergone bariatric surgery is advised to delay her pregnancy for 1 to 2 years after surgery, because otherwise, if she gets pregnant during that period, the patient is still having a lot of nutritional deficiency. Because part of her stomach has been removed, all the nutrition doesn't get absorbed, she develops a lot of deficiencies. And this can be a risk for the baby. The baby may be born with low birth weight, prematurity, and with nutritional deficiencies in the baby. On the other hand, in the mother, there are many benefits where there's a reduction in the risk of developing diabetes during pregnancy and reduction in the risk of having a large baby following, developing diabetes during pregnancy. So even the international guidelines tell us that bariatric surgery is currently an experimental therapy in women with PCOS. It should be just the last resort, nothing to be done as a first line. It has to be the last thing you will do, and advise this to a patient as fertility therapy. So the key messages I would like to give is that the key to successful treatment depends on reduction of the body weight in PCOS women, bring on a healthy change to diet, increase physical activity, helps to bring down the insulin resistance, brings the menstruation regular, increases the fertility, and helps to lower the male hormone. And the lifestyle modification in lean PCOS is also needed. She still has to exercise, as discussed last time, because that will help her to reduce her insulin resistance. Lower the BMI, lower the waist circumference. It's a marker of success for infertility treatment. On the other hand, if one does laparoscopic ovarian drilling, it's an option, but we have to use this very, very judiciously. Only those women who do not respond to oral or injectable ovulation should think about using this therapy. And those who cannot afford injectable therapy every month, because these hormone injections are pretty expensive. And the third is that they cannot come for monitoring of ovulation whilst on injectable treatment. A lot of our patients come from out of town, sometimes from small towns where they don't have facilities for monitoring, and they're not prepared to stay for that whole 15 days of monitoring in Bombay, which is such an expensive city. And therefore, they prefer not to undergo injectable treatment. And if oral treatment helps them, it's great. Otherwise, sometimes they are subjected to laparoscopic drilling. Bariatric surgery can be considered for women more than 35 BMI with other morbidities like diabetes, high blood pressure, obesity, etc. But it should be resorted to only those women if they are not responding to any other treatment, and considered still not very right for a woman who wants to get pregnant and have a baby in future. So thank you very much for having me here and speaking to you on the subject of PCOS and fertility, and talking about ovulation induction part 2, which we have finished. And we look forward to the next episode, which is coming in very soon. And we are going to speak on assisted reproduction, which includes IVF, ICSI, all the things, egg donation, surrogacy, everything will come under assisted reproduction. That is on 31st March, 3 to 4 p.m. And I look forward to seeing all of you there. And thank you so much for being with us. Thank you so much, Ruby, for giving me this extra time.
Thank you so much, ma'am. I think the more we listen to you, the more we learn. And I think day by day, the number of participants are increasing. So I want to thank all the attendees, first of all, to being patiently with us and understanding these technical things. And they're also learning all this so that they don't get lost in the Google world. Ma'am, I can see a few questions. Okay. This is a very technical session, but you made them understand so easily that if you don't respond to oral medications, there is hope. Okay, you may have other options to undergo treatment. It may not be IVF directly, but before IVF, there are many things you can do.
Correct.
So, ma'am, there are a few questions. Some of them are technical. One question is there in the audience, which is the patient is asking that what are the chances of having twins in IUI? Because you said we need 2, 3 eggs to be produced. Because in IVF, they must have heard that you get twins in 3. She's asking, are there any chances of having twins in IUI also?
There is a slightly increased risk of having twins, and more so with IUI, because you see, when the egg is released inside the body, there's no control on how many pregnancies can occur. And therefore, we don't attempt to have more than 2 to 3 eggs. In an IVF, on the other hand, we can put in only one embryo inside and control and prevent, because we are making the embryos outside the body and we are transferring the embryos in. If I transfer only one embryo, chances of her having twins is almost nil. Unless we had a patient where we put one embryo, and because there was a family history of twins, that embryo divided into 2 and she still got twins. So
Okay.
we have to remember that.
Because that's very ironical that PCS women have so many eggs, okay, but they're not able to conceive. And now, if they're able to conceive, the fear of multiple pregnancies again. I think that's a fear of every PCS woman. If they don't have children, is it okay? Or if they have too many children, is it okay? So that's a problem.
So the answer to that becomes IVF today, because today with IVF we can control the number of pregnancies which can happen inside.
Ma'am, but yeah, but I think only when they listen to the next episode, they will realize what is IVF,
Yeah.
and how convenient it is to do and how economical it is to do. And in the meantime, I request all the participants to please add more questions in the Q&A box, because I will take up the questions. We have 10 more minutes to go. Ma'am, I have a very, very specific question. Anuradha has asked this question. Okay. I am 36, married for last 6 years. I have fibroid also. We have tried IUI 2 times. Okay. Once I had one miscarriage, and she also knows her AMH, it is 1.3. Now we don't know, ma'am, what to do. One doctor saying IUI and one doctor saying IVF. We are very confused. Also, they've already spent money now.
Yeah, sure, sure. See, I would say I don't have all the other details, but the fact that she's tried 2 IUI cycles, Anuradha, probably the tubes are open, number one. The thing is that why you're not conceiving, I do not have the details, but I'm sure the doctor must have told what is the reason of not conceiving. The reason why the doctor may be offering IVF because already you're 36. And as you get older, the chances of getting pregnant go on diminishing because aging comes in the way. So before one goes into IVF, one should make sure that there's nothing inside you which is even going to prevent you from getting pregnant with IVF. So even with IVF, there's no 100% guarantee. You can see the eggs when you get them out of the body. You can see the embryos forming. You can see the quality of the embryos visually. But when you put it inside the woman, if God forbid she's got her hormones all wrong, she won't conceive. So it's important, especially a PCOS woman has to make sure that her hormones are all in order. I've seen patients who have gone through IVF without doing a single blood test. Believe it or not. I mean, I've seen that happening. And what is important for us to know is she diabetic? Is she insulin resistant? Has she got male hormones which are high? Has she got prolactin high? Has she got a thyroid high? So if there's any problem with any of the hormones, all should be corrected. Try a good cycle maybe with injections and IUI. And still if it fails, don't have a deadline by which you will decide that no, now this is enough, I'm going to go into IVF. So we normally say if a woman is younger, means she's under the age of 35, and she tries with IUI, wherein, there's no other factor. Everything is normal, but she's not ovulating well. And she's got PCOS, she's irregular. So what, we correct the hormones. We do ovulation induction, first with tablets. Then next cycle, if it doesn't work, then with the tablets and IUI. It doesn't work, just add the injections. If it doesn't work, we try 3 to 4 cycles. And if a woman doesn't conceive in those 3 to 4 cycles, which are well monitored, well done, without and treating all the abnormalities, and still she doesn't conceive, then I think the call has to be made to go into a more advanced procedure, which is IVF. So every patient is different. It's very difficult to guide a patient with just 2 or 3 reports. But one has to keep in mind that Indian women reach menopause at an earlier age compared to American and British. So they reach menopause at 52, 53. We reach menopause at about 48, 49, about 5 years earlier. And this is confirmed information. So when we reach menopause, 10 years before our menopause, our eggs start going for a toss. So it becomes more and more difficult by the age of 37 or 38 in Indian women to get pregnant easily. They do require support. Of course, there are those few rare ones who get pregnant on their own and come, which is very good. I'm very happy for them. But aging, growing beyond 37, 38, we have seen it causes problems. Therefore, we are telling a lot of career women who are delaying pregnancies, no problem, you delay your pregnancy. But say, maybe freeze your embryos and keep if you have a partner. If you don't have a partner, freeze your eggs and keep. If you do that, you won't have the stress I've seen single women who have got, who are not married till 35, 34, 35, don't have a partner. Then just because they want to have a baby, they are in a hurry to get married, not being sure whether they're getting married to the right person. So this is what the advice is, that if you're 32, you have no partner, you're not dating anybody, you still haven't found somebody to date with or happy to date, it's still going to be another year, even if you date somebody, to decide whether you're going to get married. After you decide to get married, then you want to spend at least a year with that man to be sure that you want to have a baby with him. So by then you're going to be 34, 35. So if you're getting married late, have a baby early, doesn't matter. Or the best way is by 32, if you're not sure when you want to have a baby, just freeze either your eggs or your embryos, and it's like an insurance plan. It just works well.
Yeah, I think, ma'am, but my question, this is my question. Fibroids may not be the concern, right? It could
It
be your
depends
age
how big
more
the
than
fibroid is. It
fibroid.
depends how big the fibroid is and where it is located. If the fibroid is sitting on the top of the uterus, it's not going to affect the baby at all, the pregnancy. It's called a subserous fibroid. It's sitting on the surface of the uterus. But if it is in the cavity where the baby is going to implant, then yes, it comes in the way. We have to remove that fibroid before letting her get pregnant. And once we do a surgery for fibroid, then for 3 to 4 months, we tell her not to get pregnant. So various things happen. Sometimes the fibroid is so big that it's coming in the way of us reaching the eggs in the ovaries, especially if the fibroid, this is the uterus, if the fibroid is here and we want to reach the ovaries when we are doing the ovum pickup, IVF, the fibroid can come in the way. Or if she's going to go through an IUI, no problem. The fibroid, if it is sitting outside the uterus, it's sitting on the surface, there's no problem at all. But if it's in the muscle, it's big, more than 3 centimeters. If it's in the cavity, and even if it is 1 centimeter, it needs to come out. I hope that answers the question. Hello? Yeah.
Hello, I hope you can hear me, ma'am.
You're muted.
Okay. I hope you
I
can hear.
hope you can hear me, ma'am.
Yes, now I can hear.
Yeah,
Yeah,
sorry.
sorry, I had a network issue. So, ma'am, I think that patient needs a complete thorough evaluation before
Yes.
deciding what IUI or IVF. Okay, ma'am, this is not related to any technical question. So there are 2 questions. I'll take the first non-technical question. Ma'am, this patient is asking why our grandmothers used to have 8 to 10 children, even if they were 40 or 50. And today we have so many problems.
Yes, I totally agree with that. They used to have children at a very young age. They used to get married by the age of 13, 14. As soon as they reached puberty, they were married. They never followed contraception. They went on having children. They had the first child, they are breastfeeding for a year. Then the second child comes after that. So if you see between the children, there'll be hardly 1.5 year, 2 years gap. So if they've got married at 15 and had the first child, by having 10 children, they've reached 35. So many grandmothers I've seen who are already grandmothers at 40. They are pregnant themselves, the woman, and even her daughter is pregnant. So often we have seen that happening. So it's only a question of, and of course it's our what you say, lifestyle. A lot of lifestyle. Obesity comes in our way. Then smoking comes in our way. There are so many women smoking. That smoking is the biggest harm you're creating to your ovaries and eggs. Smoking is a big no-no. Plus, they lived in probably better, healthier environments than we are living in our cities, with sort of so much exposure to dust and pollution and gas emanating from petrol. I think our ovaries are getting damaged much earlier than what they were doing before. So I think it's early marriage, no contraception was giving them their pregnancies faster and earlier.
Okay, I think it's also not only the number of eggs, ma'am. What I understand from your presentation,
Age.
it's also the quality of egg, which
Absolutely.
is directly dependent upon the age of a woman.
Yes.
Okay, ma'am, there's a question from Ankita Agarwal. She's asking, is liposuction recommended for waist circumference reduction?
No, liposuction is fat removal only from the subcutaneous tissue. Subcutaneous tissue means the fat under the skin, which only helps you cosmetically. But what fat we are talking about in PCO patients is the fat within the abdomen. Like it's around the intestine, it's around the liver. So such patients, when we open up, you won't believe it. We open the abdomen and all the fat is popping out from inside. So liposuction doesn't go inside the abdomen. It's just under the skin, the fat under the skin. So in short, to some extent, yes, cosmetically, it may help you to feel better. You may feel that the contours have come back, your fat is, you're lesser in weight, but it's not going to help your hormones in short.
And we'll take the last question of the day. Okay, now this question is, if the first child is by IUI or IVF, can the subsequent pregnancies be normal, or do I have to repeat the whole treatment?
To be honest with you, I've found in many women, the first time they are so stressed, that that stress comes in the way of getting pregnant. And actually nowadays I've started offering them acupuncture, and sometimes I feel it relieves their stress and they do get pregnant without doing anything else. So the question is, it's a well-known fact that stress is something which comes in the way. Then the second pregnancy, second pregnancy just happens because the stress is gone and they get pregnant. So often it happens. So I think in the first time, it is more pressure, peer pressure. This one's pregnant, that one's pregnant, I'm not pregnant. It's a social issue. Every time you go for a party, 10 people asking, oh, how many children do you have? That's the first question everyone asks. And that's upsetting to a woman. And therefore, it can cause problems in terms of, a lot of stress because of not being able to conceive. And that increases the stress, which prevents them from conceiving. So many of them, after 3 to 4 months of treatment, we tell them, go for a vacation, come back, and then we'll see. And they get pregnant and they come back because we have tested them, everything is normal. And so we say, take a break, take a holiday, come back, and they come back pregnant. So stress is definitely there as a scene. And the second pregnancy can happen spontaneously, unless the cause is different. There could be a cause which is repetitive, wherein the person will require help again.
Ma'am, this is the last question which I want to ask you. Okay. This is not by any audience. This is I want to. So there are some women who have OH, hyperstimulation of ovaries. So because there are so many eggs produced and we don't want, suppose the cycle is cancelled or the eggs are removed. So because the number of eggs are reducing, cycle after cycle, year after year. So does it have any impact, or if she has to go for an IVF after 1 year or so, will it have an impact because her eggs are getting wasted?
No, we don't waste the eggs. When we do, suppose if she's undergoing IUI, just 2 or 3 eggs we are creating, right? Anyway, what happens is with every egg which grows, there are another 20 to 25 eggs grow along with that egg, as I showed in that first graph. It's only one egg in the natural cycle. Only one egg becomes dominant and the other eggs just get, they die a natural death. So in every menstrual cycle, you're losing 20 to 25 eggs with one egg allowed to grow. Now, when we give oral ovulation induction, the medicines, we are not creating more than 2 to 3 eggs at a time. That means what is happening out of those 20 eggs which are going to die, we are able to save 2 or 3 of them and prevent them from dying, allowing them to grow. When we do IVF, we are giving the hormone injections. With the hormone injections, we are trying to save the balance 20. May say we are able to retrieve at least 15 or 16 of them and allowing them to grow. So in short, we are saving all those eggs which grow. Instead of cancelling a cycle, if we have a facility for IVF, we recommend to the patient, let's get these eggs out, let's freeze them. Don't waste them. Don't get pregnant in this cycle, let's freeze these. And then in the next cycle, you don't even need to undergo stimulation. Those embryos which we have created outside in the laboratory with her eggs and with her husband's sperm, we just put them inside the uterus after giving some oral medication. We don't even have to give injections. So we are not wasting any eggs. They are too precious to be wasted. We can't waste them.
Correct. So this is exactly what I want everybody to learn in the next session, that IVF may be a better option. Don't get scared of the word of test tube baby or IVF. We need to get our concepts very clear So for which I will request ma'am to come back to us and give a talk on that. Today we will end the session here. We will just go back and see the participants have learned. Before that, I want to thank you, ma'am, so much for answering the questions and giving such a lovely presentation.
Thank,
Really, thank you so
thank
much.
you so
Now
much.
let's test what the people understood. So I will go back and conduct the same poll, okay, after the session to see if your answers have changed. I would request first question to be displayed on the screen, and we will get same 30 seconds for everybody to answer. Can I have question number one on the screen, please, for everybody to answer? Uh, the questions remain the same, okay? You may change your answer this time based on what information you have got. Question number one is, many women with PCOS and irregular periods do not conceive spontaneously. When I had asked this question initially, about 60% of you all said true and 40% had a different opinion. They said false. So now after the session, we still have, and I think 50-50 is the response by people. 50% of y'all think natural conception is possible and 50%. So ideally, I think those women with PCOS with irregular periods may not conceive spontaneous. They may require some or the other treatments. The correct answer is true. Okay. We go on to the next question, please. Question number two is, injectable hormones for ovulation induction are used for all PCOS women having difficulty in getting pregnant. Injectable hormones for ovulation induction are used for all PCOS women having difficulty getting pregnant. So, do all women require injectable hormones? Is the question. And we have last 2 seconds, and 100% of you have answered that it is false. Earlier, when I asked this question, about 20% of you said true, and now all have answered false, and this is the correct answer. They all don't need injectable hormones. We move on to the next question now, question number three, which is, we can safely use hormonal injections for fertility without any medical assistance. Is it true or false? We can use hormonal injections without any medical assistance. And so far, everybody has said that no, you definitely need medical assistance because you have to keep monitoring the follicular growth. You have to go for sonographies. You need someone to monitor it. So the correct answer is false. Yes, you need to have medical assistance before you continue injecting hormone injection. Earlier, 83% said false, and now 67%. So let me tell that the correct answer is false. You need to have a medical assistance and a continuous monitoring while you're on hormonal injections. Question number four is, the risk of injectable hormone treatments are ovarian hyperstimulation syndrome, which is OHSS, and multiple pregnancies. Is it true or false? Earlier, 100% of you mentioned true. Let's see if you have a different opinion this time now. That does injectable hormone lead to OHSS and multiple pregnancies? Is there a risk? So 100% of you again answering, all of you have the same opinion that yes, they may cause OHSS and multiple pregnancies. So the correct answer is true. Question number five is, laparoscopic drilling is offered to women who do not respond to medical ovulation induction. Is it true or is it false? Is it offered to those who do not respond to medical ovulation? When do you opt for ovarial drilling? When you see that there is no response of the medical, or you put everybody for laparoscopic drilling. Right now, majority of you are saying that it is true that you need to offer it to those women in which there is no response to the medical ovulation. Earlier, 60% of you said uh, true, and now 75%. So the correct answer is also true. It is only offered to those who have no response to ovulation induction. Only then you might offer a surgical option, which is a laparoscopic drilling. 25% people who answered false is not correct. Over to the next question now. Question number six. Laparoscopic drilling is the first line of ovulation induction. Is it true or false? Is it the first line of ovulation induction? I think you have a hint from the previous question that when is it given. So earlier, we have mixed responses again, like earlier. Earlier, 83% said false, and now 67% said false. Well, the correct answer is false. Now, the reason being, it is not the first line. It may be a treatment for PCS women, but it is not the first line to induce ovulation. Okay, there are other first line of treatments, but not of laparoscopic drilling. So, the correct answer to this question is false. Last two questions coming up on your screen. Question number 7 is: bariatric surgery should be offered to all obese women desiring fertility. Is it a solution for all the women? That's the question. Is it true or false? Bariatric surgery should be offered to all obese women desiring fertility. So far, 100% of you have said it is false. It should not be offered to all obese women. There are other treatment modalities also. And the correct answer is this only. The correct answer is false. Earlier, 67% of you all said false, but now all of you have given the correct answer, which is false. It's not the only option for obese women. The last question coming up on the screen is question number 8. PCOS women who over-respond to injectable hormones should be recommended IVF. Now, this is somewhat, similar to the question which I asked, madam, in the Q&A segment, that, ma'am, if there are multiple, eggs and they're over-responding to the hormones, should they get converted this cycle to IVF? So, I think there's slight confusion in the answer, but the correct answer is true, because all those who over-respond, okay, that have the injectable hormones, they have many, many eggs now. They should be recommended IVF because we can utilize that egg to freeze the embryos and then use it for IVF. The correct answer is true in this question. So this brings us to the end of today's poll. Okay. All of you have learned a lot. I see a lot of variation in the answers coming up. And I think this is only possible because of the lovely presentation that ma'am gave. And I want to give a warm vote of thanks to ma'am, who is the president of the society. Thank you so much, ma'am, for giving such a lovely talk. And this is possible because of the entire team working behind the curtains. I want to thank Dr. Shobna Paddar. Ma'am is the chair of the special interest group, along with me. And this entire team of Vijeta, who's working tirelessly, uh, even if they are fasting today, whether it is the Ramadan fast or whether it is the Navratri fast, they're all working tirelessly so that we can bring this information to all of you. And I request all of you to bring in more people to hear or learn a lot about this. In case if you have any queries, please write an email to manager.vijeta.pc@gmail.com. And you can access all the videos of all the episodes so far on our YouTube channel of the PCOS Society of India. Please log into our website www.pcos.org, where you can get the link for everything. And all this is possible only because of Philips, who has been supporting us in this initiative. So I want to invite all of you to the next episode, which is coming up and specifically talking about IVF. So I request all of you to join on the 31st of March. At the same time, 3 to 4, and learn more about it. So it's not going to be only of IVF. Ma'am will also cover more about assisted reproduction, whether it is IVF or it is surrogacy or it's donor eggs or donor sperm. So I request all of you, this will be the last episode of the season before we have a panel discussion where we will have a multidisciplinary team. We will have a diet discussion on the diet. We may have an endocrinologist. We may have a dermatologist to discuss all the different issues together as a team, because PCOS treatment is all about collective treatment, and together we can be Vijeta. So I thank everybody for being here with us in this afternoon. Once again, I request all of you to join in the upcoming session. Once again, thank you, ma'am, so much. And I wish everybody a lovely evening and see you all soon in the coming up episode. Thank you so much once again.
Thank you. Thank you, everybody, for being with us. Thank you, Ruby, for doing a great job. And on behalf of PCOS Society, I thank all of you for being with us. And I would love to have a feedback on what's going on with our delegates or women who are listening to us, and tell us all about where we could go better and how we could do better, and how whether you're enjoying the talks or you're finding them too difficult to understand. Do you want them simpler? Do you want some other subjects, etc., etc.? I think a feedback form we send out to everyone and get their inputs. It'll help. Thank you.
Thank you.
Thank you. Bye-bye.